On behalf of the research of the team that worked on this particular project within the overall program, Jason, who's here and we're co-presenting, he'll probably be presenting most of the things, and Jitendra, and who is also online, I hope. Yep. So before we start, and we in Australia we have a custom of acknowledging country. I acknowledge the Bedigal people of the Eora Nation as the first custodians of the land on which I work. I pay my respect to elders past, present, and emerging. This, I basically just introduction, put it into context. Some of you, I can't see who the participants are, but some of you may have seen this, which is part of the research program that we're conducting through the university as well as the WHO Collaborating Center. The program includes 4 functional areas. One is to research into readiness of organizations and people to connect digitally. And we look at digital health capability maturity, which is a system to measure and to assess maturity, conduct digital health assessment, digital health projects. 2, to connect data and systems. 3, to connect services and professionals. And 4, to connect citizens and community. So to connect data and systems is one of the underpinning mechanism on how we conduct this particular project that we will be presenting tonight on continuity of care. So we do data linkage, assess data quality, and harmonize or map the data that we collect through our systems into a common data model. And then we do machine learning and other AI-driven data analytics on the program, on the data set. To connect services and professionals, one of the key projects is the continuity of care. So I'm sure all of you would have heard of continuity of care, and we'll be presenting on how we actually use our data to develop methods and processes to help us understand from the data point of view a continuity of care and how it relates to the patient's journeys and how the professions who take part, or the professionals who take part in the program and have their identification on the, can be noted in the data set and how they interact with the patients. So we look at this continuity of care in the context of integrated care, multi-level integrated care, primary, secondary, tertiary. There's a program that we're looking at called STEP Care for Kids, where we worked on integrated care with co-consulting models between pediatricians and general practitioners to understand that process of integrated care and how we can use our data to support that. And continuity is part of the kind of framework for integrated care. We're particularly interested in autism. And we also particularly also involve ourselves in telehealth and mHealth programs. So this Watch Me Grow is a pediatric app where we focus on child development through engaging the parents with tablets and other phone apps. Finally, the program includes citizen and community engagement. Actually, are focusing a lot on how the health networks and general practice and primary care and community health people connect with local government and the community to support and sustain integrated healthcare services. This map here is where we actually do the research. There are a couple of neighborhoods where we collect data from. This is in Southwest Sydney. It got a range of general practices and different size solo practitioners and up to large group practices. And we link that data from general practice with data from hospitals, community health, emergency departments, and ambulatory care. So that's kind of the background. This is how we get the data out from the general practices. So if you look at this is a bit of description of the platform to extract and use real world data, RWD, in the title here. I just want to make sure, Cha, can you hear me and can see the slides?
Yes, Professor Teng.
Okay, thank you. This is a neighborhood, right? This big graph here, and a big blue blob here. There's a GPs, apps, and wearables, GP systems where we extract data from. This is all in development. We haven't collected, except for apps data that goes into a GP system. We haven't collected any of these wearables data yet. And then we also collect data, extract data from the emergency department, community health centers, and outpatient clinics, and hospital admissions. We extract it, anonymize the data, and transform it into the and load it through the firewall after it's been anonymized. So outside the firewall of the general practice or the hospitals or the emergency departments, the data is anonymized, and we store it in a secure database and link the data here. And after that, once this anonymized database is linked and cleaned, we export it across this particular firewall and work on the data analytics in the university environment, which has got its own firewall as well. So what we work on here is the data that we use for this analytics, which we use this project as an example to demonstrate. So it is a standardized database conforming to a common data model, because we are extracting data from different systems, general practice systems, of which there are two different major ones that we extract data from, and the hospital system, which is a Cerner big enterprise architecture enterprise system. So we have a standardized database of data that's linked from all these sources and is anonymized, and it becomes a data set of anonymized individuals that we use for data analytics and conduct what we call PLP, or patient level prediction, and PLE, population level estimation studies. So basically, we looking at both individuals as well, clinical research as well as population level research. So because we use a common data model that's consistent with international community called the Odyssey, Observational Health Data Science and Informatics Community, we can link up with them to do international cohort studies and run trials. But more importantly, the data that we have actually cleaned and analyzed the data quality from, we feed it back to our sources, the hospitals, EDs, and the GPs, so that they know how good their data is, and then they can start to use it for their own purposes, and also mainly to see what important questions, important gaps they need to address. So that's kind of how we collect the data and get the data ready for this continuity of care study that we're presenting tonight. The model that we kind of frame our research into is the chronic care model, which I'm sure many of you would have heard of. It's something that the WHO is and various other people working in the chronic disease domain are familiar with, because it involves a very comprehensive approach to how we can improve the way we interact with the patient here and the community, and we interact either as a team or as individuals. All right, and to have a therapeutic relationship, and by doing that, we can hopefully improve population health outcomes, functional health outcomes, and clinical outcomes. The chronic care model covers this bit, which is focused on the community as well as health system. So all the way from policy level right through to information systems. All right, so good, healthy public policy, supportive environments, regulations, and so on. Strengthen community action in the local communities, especially. and empowering the individual with self-management skills, delivery systems, models of care, decision support, not just from information systems, but also generally. So that's kind of the model that within which we work. And the other model that's relevant to this, what we're going to present tonight is continuity of care. A lot of us understand continuity of care to be composed of three elements, three categories. One is informational continuity, and you have information about the patient and their families. The second one is management continuity. All right, these are evidence-based protocols which give a consistent approach to changing patient needs. So the management plan that is co-developed with the patient and is agreed within the team. So you have a consistent management of the patient by the team, because at the end of the day, we also talk about relational continuity, which is interpersonal. All right. And it's quite hard to have interpersonal continuity these days because a lot of doctors in Australia at least work part-time. But even in places where we work full-time, it's very hard. You still need the doctors and then other healthcare professionals need to go on leave and so on. So we're talking about a team continuity as opposed to just interpersonal continuity. Of course, we aim for interpersonal continuity, but a lot of the times, or some of the times, we just can't provide it. So we need to have information continuity as well as a management continuity, which is evidence-based. So these three elements work together to promote an ongoing therapeutic relationship between the patient and the team, and trust within the context of a medical home. So that's the two main frameworks that I want to share with you to provide the background to this project that we're going to present to you tonight. So how do we measure continuity of care? So as I have consciously decided not to give you a literature review and stuff like that, because we are familiar with the concept and we know it actually is a good thing. Most of the evidence suggests it's good, and is a defining characteristic of family and general practice, and is a core attribute of primary care. So information continuity, as I mentioned, is, if you're going to measure it, you're going to measure how organized is the collection of medical and social information about each patient. So that's a process that we need to have measures about. The longitudinal or the management continuity talks about a medical home. And so some of the indicators will have to look at how well the organization is available to support a team, either in one place or virtually, to provide continuity of care that is both safe and effective. And that includes both acute care or treatments as well as preventive services. Interpersonal or relational continuity is another important one, as mentioned. And there are indexes that we can use to measure that. And Jason will start, and we develop methods of doing that from the literature as well as using the data that we have. So I'll hand over to Jason now to look at the indices and the methods and some of the results that we'll be presenting. Thanks, Jason. You got it, Jason?
Hello, Sir Jason.
Oh, sorry, I'm muted. I didn't know. Yeah, Teng, I think you can keep sharing your screen.
Okay.
I'll just continue from your slides.
Okay, all right.
I can't see your slides. Should I share mine instead or?
Yeah, I'll share the screen now.
Yep.
Can you see it now?
Yeah, it's coming on.
Okay. Right?
Yep, I'll request control. So I think you can just allow me
Prove
to.
that, yep.
Yep, and I should be able to go from here.
Yep, you got it?
Yep.
Okay.
Yeah, so yeah, just to start again, so primarily for this project, we are actually measuring only the longitudinal continuity, and there are several indices or different measures that we can use to, I guess, measure the continuity of care. And we picked, I guess, two of the most common and I guess applicable to our data set. One is the the Bice-Boxman continuity of care index, which is the first equation, and that that measures the dispersion of providers visited at the patient's level. So just, I guess, without having to understand the equation there, it measures how dispersed a patient visits the different care providers in, I guess, around the home or in the network. And for this equation to apply, you have to have at least 3 visits to a general practice provider within the study period. And another measure is the UPC, which is the usual provider of care index. And that essentially is a proportion that is given to the highest number of, I guess, the provider that has the highest number of encounters with the patient over the total number of encounters of a patient. So essentially, if a patient visits Dr. A 6 times and a number of other doctors, 1 or 2 times, so that makes the total number of 8 visits. So the usual provider of care index is that highest number of doctor visit, which is 6 over the 8. So that provides you a usual provider of care index. And so we use those 2 indices, and we wanted to associate that with some of the outcomes, or I guess the most commonly studied outcomes of continuity of care. And one of them is the looking at the ambulatory care sensitive conditions. And what this set of, I guess, conditions is defined as the clinical conditions for which the risk of a hospital admission can be reduced by effective and timely ambulatory care. And the list that we used is modified by, so the list that we use is adapted by IHW and for, I guess, for the Australian context, but the main list for the ACS conditions has been widely used in various studies, and it contains, in our case, 21 conditions, which includes hypertension, diabetes, various conditions that can be if well managed by the general practitioner, have shown to highly reduce the likelihood of having any hospital admissions. And I guess another outcome that can be studied is the mortality index or mortality rate, which is not looked into in this project. So I guess most of the work in this study has been heavily based on the Barker et al. Study, which looked at the association between the continuum of care in general practice and hospital admissions for the ACS conditions. It's a cross-sectional study of routinely collected data, personal level data, and they use the usual provider of care index as well as the COC index, and associated with the socioeconomic status, number of pre-existing long-term conditions with the ambulatory sensitive admissions. So they had data of at least 1 year before the index date and 2 year of follow-up data, and they removed any poor quality data. And in the final cohort, they had approximately 230,000 patients, and the data sets are collected from the UK. So some of the key highlights in this study. So they found higher UPC was associated with less hospital admissions for ACS conditions, and this, also age, number of pre-existing long-term conditions, as well as visits, GP visits are all positively associated with the number of ACS condition admissions. So this, which led us to just start off by replicating the study with our data set. So as Teng previously showed in a slide at the beginning, where we have data extracted from the hospital admissions, and we also have our GP network, and the numbers present the number of patient records. So from the approximately 1.8 million patient records, we applied our exclusion criteria, and the same with the GP. So those exclusion criteria are the exact same as the Barker et al. Study. And after applying, and we did our linkage between the two data sets, and we ended up with 10,000 and around 10,500 patient records. So moving is just looking at the demographics of our data set. We split the group into low, medium, and high UPC index. So the low group is 0 to 0.4 UPC index, and the medium is 0.41 to 0.7, and high is 0.7 to 1. And here's all patients on the right. So we can see we have about 53% females in our data set, and given our exclusion criteria which included patients of only 62 to 82 of age, the mean age is around 70 years old. So just quickly moving down and looking at what the number of encounters, etc., across the different groups, we can see that there is an increase slightly of the number of long-term conditions as the level of continuity increases through the different groups as well. And however, looking at the number of admissions for ACS conditions, it seems that we actually have a decrease as the ACS goes, the number of zero admissions actually decreases as we go up to the high level of continuity group, which is sort of indicating that we're looking at something that's opposite to what the Barker et al. Study has found. So just looking at a quick comparison of the distribution of UPC index. The darker color is the ePBRN dataset, and the blue is the Barker et al. It does seem like a fairly similar distribution, where Barker et al. Did seem to have a higher, 0.5 UPC index in the cohort. Just looking at the next table here, which lists out a number of predictors of hospital admission. Here we see that years of age is a significant predictor. like I said previously in the other slides, we actually found a slightly different result for UPC index. But here in our data set, it's insignificant, but possibly just due to how our number of patients might be much lower than what the Barker et al. Study had. Similar with the GP visits, which is also significant, and the number of long-term conditions and gender.
Just a comment before you go any further,
Yep, sure.
Jason, is that, I mean, for those of you, our participants here, I guess different, Barker study was UK, our study is Australia. The Barker study is a much larger study, has about 230,000 patients, and we have about 10,000 patients. So, but having said that, continuity of care has, while it's good, some of the conflicting changes, you know, obviously you've got to think about statistics, but at this point in time, we are more interested in the methodology as opposed to the results. And some of the findings might reflect not poor continuity of care, but maybe better quality of care or vice versa. So there's a whole range of ways you can interpret the data.
The next slide here. So that's now essentially just focusing on the change in the UPC groups. So comparing between the groups medium versus low, high versus low, and high versus medium. Here we can see all three groups in the Barker et al. Study, they found a significant, I guess, change between the groups. But we didn't find those changes. But what I want to really highlight here is that we did find the opposite, I guess, an opposite effect where Barker et al. Would have, as UPC increases, their hospital admission decreased by, you know, medium to low, there was 8.96%, where our one actually increased in our data, increased 4.9%. And here it's almost the reverse. Ours increased by 13.4 and Barker et al. Decreased by 12.49. But given those insignificant p-values, we did want to, I guess, investigate this further in our data set, which I will present some of the results right after this slide. So this is another table that Barker et al. Study had, and we replicated in our data set. We had a very similar finding where most of our results didn't have any significant difference, where we can see here in the sorry, I just want to quickly explain this table. Is so this table broke down the number of GP visits. So essentially in the first, second, and third, fourth, and fifth, it's broken down by the number of visits to the GP, and with I guess the UPC index, and then here we can see with an increase of 0.2 of UPC. So here we can see that in the Barker et al. Study, there's a number of groups that had a significant difference when there was an increase of 0.2 UPC, right? So in the second, in the fourth, and the fifth, we did not observe any of that in our data set. So which leads on to us wanting to sort of adapt the study and make it have some of the results that could be interpreted and have significant number of, I guess, increased number of patients that we can get some significant results to actually compare with some of the recent studies. So we had the same number of cohort, the same cohort here from the beginning, and we linked it So we slightly took a different approach, and we linked the patients first, and then we changed the exclusion criteria. So we included patients from age of 18 all the way to 100, and we increased the number of, so the study period from 2 years to 4 years. And we also wanted to use the COC index in addition to the UPC index, which, like I previously mentioned, requires at least 3 visits to the GP instead of just 2. So now we ended up having a cohort of around 65,000 patients versus the 10,000 patients in the exact replication of Barker et al. So looking at this, the new table here, we have a much larger cohort, and we can see the number of females, or the percentage is now 55%, and the trend that we've seen in the previous cohort still exists. So as the UPC, or now we use the bispecimen, the COC index, as that increases, we're actually getting, I guess, less patients without any hospital admissions for ACS conditions. So this is the same as we observed in the first cohort. So now looking at the predictors for the hospital admissions for ACS conditions, and we could see that now UPC index does have a significant is a significant predictor. So is the COC index, and the rest all stayed the same, or all stayed significant in the new cohort. So now looking at the group comparisons, medium versus low is now significant and is still showing the same as what we found, I guess the same change direction, such that with the medium versus low, we actually had an increase of 1.7% in hospital admissions. Here in high versus low, we have a 5.4 increase in admissions as UPC increases. So just after, I guess, presenting the result, I just want to highlight some of the limitations why you might want to consider more before you want to take the results directly and say, UPC index will actually really help with looking at how the hospital admissions for those ACS conditions. We want to highlight that the data may not capture some of the patients that dropped out of the network. Because our data is quite geographically localized, patients may move out of the network during the study period, or other patients may move in to the network. So those potentially can affect the calculation of the UPC or COC index, or miscounting the number of hospital admissions if they do visit a hospital outside of the network as well. And this study also doesn't look at the order of events, such that the UPC and COC index only reflects the entire study period, which therefore can occur before or after the hospital admission. So, this means that, a GP visit could actually be a result of the hospital admission, rather than I guess a higher COC or a higher number of GP visits is actually resulting in the hospital admissions. So I guess in conclusion that the continuity of care measured in UPC and COC did both show associations with the number of hospital admissions for ACS conditions. And our results suggested that higher continuum of care was actually associated with a high number of hospital admissions in the ePBRN network. And the number of pre-existing long-term conditions, as well as number of GP visits, age, and gender, are all significant predictors of ACS hospital admissions. So I will just pass this back to Teng to finish off, I think, some of the other slides that he wanted to present.
Okay. So we've looked at how we can actually, suggest ways to use real-world data that we extract from electronic health records, or any other kind of routinely collected data in observational databases. So we've done to do the continuity of care study. We actually, first step was to look at what other people have done and then try to replicate them to actually validate and verify our methods. The second bit is actually use the same methods to do the study of our local populations. And as we flagged, the data, some of the questions that arise from here is that, the trends are interesting, but we are dealing with real world data. And it's so important to make sure that there's a good culture out there amongst practitioners and information managers to actually collect good data. So the data quality assessment is so important. So that's number one. Obviously, different country systems. But one of the big questions we have is, what is the optimum number of patients and number of encounters we need to actually start to have consistent results? It's like sample size calculations. If too small, underpowered, you get a whole range of variable data results. So that's one important thing. Two important things we can consider. Then the third one is actually the healthcare itself and continuity of care. Healthcare and continuity of care and integrated care and these other related concepts is complex. And there are positive and negative feedback systems. So like if you have a sick patient, you would tend to have higher continuity with a general practitioner or with the primary care service. At the same time, you will also have higher admissions because the patient is sicker than the normal population. So there's various factors that produce interesting results that you need to explain. You need to understand the local context. So having done that, the next step is very important to engage the practices. In the original slide I showed of how we extract the data, we provide feedback to the practices. This is that part of it. So we link the data, because we link the data with hospital services, we can look at ambulatory care services, which is outreach from hospitals. Community services, again, it is a hospital-based service or local health district service as opposed to general practice service. Emergency is emergency, inpatients, obvious, outpatients, all right, so there's post-admission and so on. And recurring here refers mainly to dialysis patients. So if you look at the different curves for each of the different sites, we're talking about a linked data set of patients from one practice. All right, so the practice can understand where its patients have been to in those different services. And if you look at it, the trends are very similar, except for this particular color is inpatient. No? Yeah. And so there's a peak there in that particular age group. And you look at it broken down by gender and age, or by gender, it is between 20, it starts to go about age 20s, mid 20s, and then 30, and around just before you hit 40. So, you expect that with maternity services and, and so on, and, female and women patients tend to use services more than male patients who are really not really too concerned about their health as compared to females. So we can actually pick up those kind of things, and the practices can start to work on their how to improve their care or how to actually engage with their demographics to improve the patient satisfaction and patient outcomes. Other analysis, so you look at, say, you can actually work out the distribution number of encounters that, so this is patient level data. You're talking about just using an example of elderly. So of this particular general practice, one general practice, some of these patients, some of their elderly patients attend ambulatory care, or in this, or attend emergency departments. Again, it's pretty obvious, right? Most of them will be one or two occasions that they go to emergency department, and it's only the sick ones that actually go there more often. Same thing with admissions, and same thing with outpatients, because it has to reflect inpatient, because it's outpatient following up, especially follow-up care. So there's this kind of data that you can provide at practice level as part of quality assurance and quality improvement processes. Even better, you know, because the extraction tool we use, remember I talked about anonymization. That means in the secondary use of data for quality improvement and for research and for evaluation, we have to work with non-identified or anonymized data. But I use the word pseudonymized, which means that for this particular tool that we use, you can, when you get back to the source data practice, like a general practice or the particular unit in the hospital or whatever, if there is ethics approval and it can be construed as part of quality improvement, the patients can be re-identified, all right, within strict privacy and confidentiality precautions. And the practice or the quality improvement people can actually, you know, use this data to highlight how they can and work with patients that they can do specific with specific patients to improve the care that's produced. But that's at the clinical level. At the practice, at the secondary use level for evaluation stuff, you need to go through the ethics committee to see whether you can do that in your particular context or not. So this the potential of the methods that we kind of currently using. So to conclude, we'll continue to validate the indexes that we talk about, the bias Boxerman and the UPC, and the data quality, and continue to harmonize with the common data model, because at the local level, our data sets, it gives us the opportunity to understand how, if we're actually using the same type of data, what's the sample size, or what is the number of patients in large data sets we need to actually get to a level where we can say the results are kind of reflect the true situation. So that's one. And currently, obviously, with the pandemic going on, we're also working on creating cohorts, starting off with COVID, but again, with the platform that we have now, we can create cohorts or identify cohorts of a range of conditions. So, you know, we can characterize the cohorts and monitor a range of real-world data elements. Models of care to monitor models of care. For instance, now, across the world, we are going to telehealth. So how does that actually start to impact the model of care, impact the quality of care, the safety of care, impact comorbidities, especially mental health, especially the sequelae of the pandemic, and the medications, and, you know, whether Plaquenil or, you know, hydroxychloroquine is actually useful or not. So along those lines. So this is kind of where we are at, and hopefully that would allow us to start to understand, not just in our own little backyard, but also across the country. We are working with other states in Australia to have a common data model to share our data of real world data. I'm talking about not research data, but real world electronic health record data. And obviously the international connections, so that we actually have adequate patients and interactions with the health system to start to understand the quality and safety of healthcare. So with that, we'll stop and ask for questions and acknowledge the participating general practices and the local health district data and the information management and technology department and the staff and co-investigators in the network and the funding agencies. Any questions?
Yes, thank you, Professor Teng and Sir Jason. So we now have a few questions here. So our first question is from Dr. Bunchai. He's asking, in Australia, do patients have to register to a GP and a hospital? Can they shop care at any GP or hospitals in the network?
I'll have a go at that since I'm the clinician. Yes, in Australia, there's no patient panels. There's no registration. You can go anywhere you like. But about 60-70% go to the same practice because of convenience. It's near and and everything else. So there is a informal kind of panel. The other question was, so the second part of the question, sorry, it just slipped my mind.
Yes, can they shop care at any GPs or hospitals in the network?
Yes, they do shop care. And in fact, we're doing a study on opioid use. And we're interested in doctor shopping for opioids. But that's an extreme case to try to kind of understand how people get a lot of supplies of narcotics. I mean, we've done doctor shopping. A lot of doctor shopping in general practice, where they go to different general practice, is because of access. A lot of children go to different doctors and emergency departments because they can't get into their doctor of their choice. So they shop around. Or they usually have 2 or 3 practices where they actually go to for just in case they can't get into one. So that's the most common reason for what Bunchai calls doctor shopping. And there's a small minority that actually shop around for drugs that they shouldn't be having.
Yes, thank you, Professor Teng. We have a set of questions here from Dr. Renu Kanand. So the first one is, what were the main challenges when you were onboarding the patients? 5,000 is a sizable number of patients for the work that's been done. Who were more receptive for these services? Is it the patients or medical professionals?
Onboarding, meaning recruiting the patients. We don't recruit the patients. We're working with real world data, with data that doctors and other members of the healthcare team collect as part of their normal practice. And that's what we mean by real world data. We don't specifically have a research, go out with a specific questionnaire to find out. And so we don't need to recruit patients. The participating practices has been approved by ethics to use the data based on what we call an opt-out consent model. So they put up notices in the general practices and in the hospital waiting rooms and so on, saying that this practice is using its data to do research and evaluation and quality monitoring and so on. We'll be using your data for these purposes. If you have any problems, please let us know and we'll take your name off the list, or we'll kind of put a thing in the widget in the system to prevent your data from being extracted. So that's kind of, I hope that answers the question. We don't consciously go out and recruit patients. We use existing real world observational data, which makes it kind of cost effective. And that's why we're doing a lot of work nationally and internationally to see how good is this in terms of running randomized controlled trials or doing cohorts, doing case control studies and so on.
Thank you, Professor Teng. So the next question from Mr. Renu Kanand is, how has COVID-19 changed the landscape and what percentage of teleconsulting is happening among this group?
That's a good question. That's a very good question. Depends on how you define telehealth or teleconsulting. With the COVID-19 pandemic in Australia anyway, and I think it's probably consistent with people that I work with in the UK and the States, it's most of the increase in teleconsultations is actually phone consultations. It's not kind of telehealth as we understand, well, as you and I understand it as informaticians. But that's not to say that telephone consultations are not good. They fulfill the role now because most of our practitioners are not digitally health ready. The maturity is not quite there yet. They're worried about using video consultations. And some of them don't have the infrastructure to actually do video consultations. They can do Skype and stuff like that, but we tell them that, until the security is not vouched, it's probably not a good idea. You might be better off just using the phone. So the increase has been tremendous in terms of phone consultations, right? Video consultation is still a minority. We still got a long way to go, and I'm sure you'll find in your own countries as well that same phenomenon. There's a great influx of telephone consultations.
Right, thank you, Professor Teng. We have another question. So I assume that the data presented here were pre-COVID-19. Have you created SOPs that can now be replicated across state lines?
Well, I mean, we don't have to create new, well, I guess yes and no. I think COVID-19 results will come in as they become available. In the early days, in Australia anyway, and I'm sure I'll be interested in what happens in other countries. In the early days, only government labs were allowed, were doing COVID tests, the PCRs, the COVID-19 tests. So there is a large data set, and Australia has only got about a few thousand cases, very small numbers. So, that's why the common data model allows us to work internationally and start to share results and have a more robust conclusions. And but after about a month or so, because we wanted, like Korea and other places, to do a lot of community testing so that we can actually start to get an idea of what the denominator is. So it starts to put a lot of pressure on the government labs. So the private labs have started to do that for the last couple of months or so of the pandemic. And so there's a whole bunch of data that's coming in as a matter of routine back to the general practices. So the beauty about doing what we're doing now is that the data set is longitudinal. Every time we extract it, after 6 months or 3 months, or depending, if we have resources, we can do it every day, but it's not worthwhile doing it every day. What we've done for our purposes, which is research and quality improvement, every 6 months. All right. So, but the protocols are in place. It's just increasing the frequency to be able to detect changes in a pandemic. So, but obviously, because of the setup of kind of pandemic control of the data by the government labs and so on, it will take about 6 months before anything becomes clear. Not because the data is not there, but because of how it actually comes into the clinical systems.
Thank you, Professor Teng. We also have other questions from Mr. Renukanand. But we're reaching the top of the hour. I guess we can connect him since he has more questions. We also have Dr. Alvin and Dr. Bunchay on the call. I think Dr. Alvin has questions.
Thank you very much. I have a few questions, very difficult ones we're encountering in the Philippines right now. Does the Australia government allow practitioners to advertise their telehealth services? Number one. Number two, who pays for these telehealth services? Is it the patient directly out of pocket, or does the insurance system pay for them? And would you recommend having trusted third parties to just oversee that the patients are actually safe and protected from bad telehealth practices?
Thanks for the question. That's very bureaucratic. Yeah, the important thing here, I guess, is it took a pandemic, the coronavirus, COVID-19, to fast forward our implementation of telephone or using telecommunication, including telephone. So that's a good thing, because the government has said that you can now use what they call telehealth, and that includes telephones. all right? And you can bill, actually you can only bulk bill. And by bulk bill, I mean, you can only charge Medicare that item number at that Medicare rate. So practitioners can now charge for telephone consults, but directly to Medicare, and then and it's for practical reasons as well. It's so much easier to bill the government than to try to bill the patient whom you might never seen before, and you don't even know who they look like, and they might have different identities, you know, kind of when they identify themselves over the phone. So that works, but the thing is due for review in September. This government funding of telehealth, all right? And I use the word telehealth to include, because that's what the government defined it as, to include telephone consultations. So it's to be reviewed in September to see how we're going with it. As I said, the preliminary data shows that a lot of telephone consultations, not much video consultations. Practices can advertise. There's no law to prevent amongst the profession, especially the AMA and the RACGP, the Australian Medical Association, and the Royal Australian College of GPs. As to some of the unscrupulous practitioners who only cream off telehealth and do not provide face-to-face services. And I forgot to add, as part of providing telehealth the practice, to be one of the criteria is that you should have provision for face-to-face services if telehealth does not meet the requirements. So that's a law. If you don't do that, you don't have that, you're not allowed to use telehealth. So does that answer your question? That there are this kind of
yes,
shall we say, checks in place.
Thank you very much. Very, very useful. Yeah. Thank you, Teng. Take care, okay?
No problem.
Yes,
Same to you.
Thank you, Professor Teng. So before we wrap up this call, may we call on Dr. Bunchai to close this session? Dr. Bunchai?
Hello.
Hi, Bunchai.
Yeah, thank you very much. You have a very good student, and the presentation is very impressive, and I think this is a good works of using the secondary data. I think we should continue to doing this and also collaborate among academia in Asia Pacific, like in the AeHIN. And thank you very much, Professor Teng and Jason and group. I think this kind of the webinar, we may be brainstorming how we gonna continue doing similar things to get our newcomer, like the informatician newcomer to participate and then discuss about their research and also their works. Thank you very much.
Yeah, no, thanks, Buncha. I think there's a room for, because it's not going to be all that expensive to just share the results of our analysis, but the sharing the results of analysis requires a common data model, so that we actually got less room for errors, by using the same architecture and the same terminology.
Yes, I think what we are now going to, heading to is the interoperability and standard base. I think OMOP, common data model for the research, is also a good. This is one of the good model that we can use for the secondary data analysis, like this one, and also collaborate on the research.
Thanks.
Okay. Thank you very much, and please keep safe, and hope you are, safe and sound, healthy in this time of the COVID crisis. Thank you. Bye.
Thank you very much. Take care, everyone. Bye.
Thank you.
Thank you, everyone. Bye.
Bye. Thanks, Jason.